The chart said successful. That's the word the attending wrote in the file. Successful. The bypass was clean. The graphs held. Every metric in that operating room pointed to a procedure that went exactly as planned. I read that chart 3 weeks later, when the family called. He had survived the surgery. He did not survive the month. His name was Walter, 73 years old, retired high school principal, sharp, stubborn, the kind of man who coached his grandson's baseball team on weekends and still mowed his own lawn. His cardiologist had recommended bypass surgery for 2 blocked coronary arteries. The recommendation came with a word Walter heard clearly: routine. What Walter never heard, what nobody sat down and explained to him before he signed, those consent forms were the actual numbers. The real mortality rate for bypass surgery in patients his age, with his health profile, not the numbers from the hospital brochure. The numbers from the published research that hospitals don't put on their websites. I'm going to tell you those numbers today, because Walter deserved to hear them before he went under, and so do you. My name is Dr. James Andrews. I'm a cardiothoracic surgeon. I have spent over 2 decades in operating rooms, performing and assisting with open heart procedures, including coronary artery bypass grafting. I have seen this surgery save lives. I have also seen it end them in ways that never should have happened. I'm making this video because the conversation I'm about to have with you is the conversation that Walter's family asked me why nobody had with him first. Before I give you the numbers, I need to give you the context, because a number without context is just fear, and fear without direction helps no one. Here is what most people believe when a cardiologist recommends bypass surgery. They believe the surgeon has assessed their specific situation. They believe the risk has been weighed against the benefit. They believe that if a recommendation is being made, the math has already been done in their favor. Sometimes that is true, but here is what the medical system rarely explains clearly enough. Surgical risk is not fixed. It is not one number that applies to everyone. It is a calculation that shifts dramatically based on age, on frailty, on kidney function, on cognitive baseline, on how many other conditions are already present in the body. The same surgery that carries a 1% mortality risk in a healthy 5-5 old carries a fundamentally different risk in a 7-4 old with mild kidney disease, early cognitive changes, and diabetes. I want you to think about it this way. Imagine 2 cars going through the exact same car wash. One is a new vehicle, 2 years old, everything functioning perfectly. The other has 200,000 miles on it. The belts are worn. The seals are aging. The electrical system has intermittent issues. The car wash is identical. The stress on each vehicle is not. Your body after 70 is not broken, but it is operating with different reserves than it had at 50. And open heart surgery, bypass surgery, specifically, does not just stress one system. It stresses every system at once, simultaneously, for hours. The heart is stopped, completely. A machine takes over. That machine keeps you alive, but it does not do what your heart does, with the elegance of decades of biological refinement. It is blunt. It is mechanical, and every organ in your body registers that difference. Here is the distinction that almost nobody makes clearly before a surgical conversation. There are 2 questions that matter. Can this patient survive the operation? And can this patient survive the recovery? Those are not the same question. And in patients over 70, the gap between those 2 answers is where most of the tragedy lives. Let me give you what you came here for. The real numbers, not the marketing language, the peer-reviewed data. Number 1, the 30-day mortality rate. Nobody leads with. When a hospital publishes outcomes for bypass surgery, they typically highlight their overall mortality rate. That number looks reassuring. It is often presented as less than 2%. What that number does not tell you is how dramatically it stratifies by age and risk profile. Here is what the research actually shows. A major analysis published in the Annals of Thoracic Surgery found that in patients over 70 undergoing isolated coronary artery bypass grafting, 30-day mortality rates range from 4% to 8%, depending on comorbidity burden. In patients classified as high risk, meaning those with 3 or more significant health conditions, which describes the majority of 70-olds being recommended for bypass, that number climbs to between 10% and 15%. Let me make that concrete. If you are 74 years old and you have high blood pressure, type 2 diabetes, and mild kidney disease, three conditions that are extraordinarily common in that age group, and a surgeon is recommending bypass surgery. The published data suggests that somewhere between 1-inch 10 and 1-inch 7 patients with your profile will not be alive 30 days after that operation. Not 1-inch 100, between 1-inch 10 and 1-inch 7. That number never appears in the conversation the way it should. It never gets written on the whiteboard. It never gets said out loud in plain English before the consent form is placed on the table. Does that mean you should refuse bypass surgery? Absolutely not. That is not the message. The message is that you deserve to hear that number, clearly, before you decide. Have you or someone you love been given specific mortality statistics before a bypass recommendation? Write that in the comments. I want to know how many people watching this right now have had that conversation and how many have not. Number 2. The complication rate that follows survivors. Here is what happens to the patients who do survive the operation and the first 30 days, because surviving surgery is not the same as recovering from it. And the complication data in patients over 70 is something that deserves far more airtime than it gets. The Society of Thoracic Surgeons database, the largest cardiac surgery outcomes registry in North America, shows that in patients aged 70 to 79 undergoing bypass surgery, major complication rates run between 30% and 40%. In patients over 80, that number exceeds 50% in most published series. What counts as a major complication? Not mild discomfort, not a slow recovery. We are talking about stroke, kidney failure, requiring dialysis, prolonged mechanical ventilation, meaning time on a breathing machine that was supposed to last hours and instead lasts days or weeks, deep sternal wound infection, which requires the chest to be surgically reopened, new onset atrial fibrillation, which dramatically elevates stroke risk going forward. These are not rare outliers. They are the statistical expectation for a significant portion of elderly patients who undergo this procedure. And here's the one that I find myself thinking about most when I am being completely honest about what I have witnessed: postoperative cognitive dysfunction. It has a clinical name, but what it means in plain language is this: a patient who was sharp, oriented, and mentally present before surgery wakes up confused. They do not recognize where they are. They are disoriented in ways that their families find deeply frightening. In many cases, this clears within days or weeks. In a meaningful percentage of patients over 70, it does not fully clear. The research shows that up to 40% of elderly bypass patients show measurable cognitive decline at 1 year postoperatively compared to their pre-surgical baseline. That is not a number attached to a rare complication. That is the trajectory for nearly half of elderly bypass patients. I had a family member of a patient say something to me that I have carried ever since. She said, "He came back from that surgery, but he didn't come back the same man. I've been taking care of a version of my husband I don't always recognize. That outcome never appears in the hospital brochure, but it is in the data, and you have the right to know it." Are you currently caring for a family member who changed after a major cardiac surgery? Tell me in the comments. You are not alone in that experience. Number 3, the frailty variable, surgeons underweight. Here is something that has changed significantly in cardiothoracic surgery over the last 15 years, and that most patients never hear about unless they specifically seek it out. We now have validated tools to measure frailty, not just age, not just the list of diagnoses on a chart. Actual clinical assessment of whether a body has the reserve capacity to survive and recover from a major physiological insult. Tools like the Clinical Frailty Scale, the Essential Frailty Toolset, the Modified Frailty Index. What the research, using these tools, consistently shows is this: in patients over 70, frailty status is one of the strongest independent predictors of bypass surgery outcomes, stronger, in some analyses, than the severity of the coronary artery disease being treated. A study published in the Journal of the American College of Cardiology found that frail patients undergoing bypass surgery had a 3-5-fold higher risk of 0-day mortality compared to non-frail patients of the same age undergoing the same procedure. Not 10% higher, 3.5 times higher. And here is what makes this clinically critical. Roughly 40% of adults over 75 meet criteria for clinical frailty. That means nearly half of the patients in the age group most commonly recommended for bypass surgery are in the category where that surgery carries its highest mortality and complication risk. The question that should be asked before every bypass recommendation in a patient over 70 is not only, are the arteries blocked enough to warrant surgery, The question should also be, has this patient been formally assessed for frailty? Has that assessment been factored into the risk-benefit calculation that was just presented to them? Ask your cardiologist or surgeon directly, has my frailty score been formally assessed? If they seem uncertain about what that means, or if the answer is no, that is information worth having. A center that is not routinely assessing frailty in elderly surgical candidates is not giving you a complete risk picture. Number 4. What the studies show about alternatives. This is the number that changes the conversation most profoundly for many patients, and it is the one most rarely discussed. For a specific subset of patients, those with stable coronary artery disease, meaning disease that is significant but not causing immediate, unstable symptoms, the long-term outcomes, data comparing bypass surgery to optimal medical therapy is not what most patients expect to find. The ISCHEMIA trial, a landmark study funded by the National Institutes of Health, enrolled over 5,000 patients with stable coronary artery disease and found that an initial strategy of optimal medical therapy, the right combination of medications, supervised cardiac rehabilitation, and lifestyle intervention produced outcomes comparable to routine revascularization, meaning bypass or stenting, at 4-year follow-up. Comparable, not slightly worse, comparable. For an elderly patient weighing a 10 to 15% 30-day mortality risk from surgery against a non-surgical path that produces similar 4-year outcomes, that data deserves to be on the table. Explicitly, in plain language, before the consent form. The question to ask your cardiologist is this: am I a candidate for optimal medical therapy as an initial strategy? And what do the outcomes look like for someone with my specific coronary anatomy and health profile on that path? If the answer you receive is dismissive rather than data-driven, seek a second opinion. You are entitled to that conversation. Number 5. The catheter-based alternative most patients don't know exists. Bypass surgery is not the only option for blocked coronary arteries. This should be common knowledge. In many patients, over 70, it is not. Percutaneous coronary intervention (PCI), which most people know as stenting, has advanced dramatically in the last 15 years. For many patients with specific types of coronary artery disease, particularly single or double vessel disease, stenting can achieve revascularization without stopping the heart, without opening the chest, without placing the patient on a bypass machine. The recovery timeline is measured in days, not weeks. The 30-day mortality risk is a fraction of the open surgery figure. The physiological assault on kidneys, lungs, and brain is substantially reduced. Is stenting appropriate for every bypass candidate? No. There are coronary anatomies left main disease, complex triple vessel disease, where bypass surgery provides superior long-term outcomes, even accounting for procedural risk. But there are many patients being wheeled toward open heart surgery who are candidates for catheter-based intervention and who have never been told that explicitly. TAVI transcatheter aortic valve implantation has similarly transformed options for valve disease in elderly patients. A procedure that once required open chest surgery can now be performed through a catheter in a catheterization laboratory, with patients often discharged in 2 to 3 days. The question to ask, am I a candidate for a catheter-based approach rather than open surgery? That one question, asked directly, has changed the surgical path for patients I have sat with in consultation. It has the power to do the same for you. I want to stop here for a moment, not as a content creator, as a surgeon who has stood in the position I am about to describe more times than I am comfortable counting. There is a specific moment that happens in cardiac surgery that no one outside the operating room fully understands until they have been in it. It is the moment after the bypass machine is disconnected, after the grafts are complete, after the heart has been restarted and is beating on its own again. You are looking at a result that, by every technical measure, is exactly what was planned. And somewhere, in the back of your mind, in the part that has been doing this for 20 years and has read every outcomes, study, and has had the post-operative conversations that families never forget, somewhere in that part of your mind, you are doing the math, not the surgery math, the recovery math, the kidney function math, the age math, the frailty math, the what does the next 30 days look like for this specific body math. I have stood in that moment thinking about a conversation that happened 3 days earlier in a consultation room, a patient who asked the right questions and got incomplete answers, a family who trusted the process and was not given the full picture, a consent form that described procedural risks accurately but did not translate those percentages into the language of a real person's life. The surgery was successful. That is the word that goes in the chart. What goes in the chart does not capture what I have seen in the waiting room at 6 inches the morning, what I have watched families carry out of hospitals, what I know from 2 decades of accumulated evidence that sits in my chest alongside everything I learned in medical school, about the distance between a technically successful operation and a genuinely good outcome for a specific human being. That distance is what this video is about. That distance is what Walter deserved to understand before he signed his name. I want to tell you about a patient. I'll call her Margaret, 71 years old, retired librarian. The kind of woman who kept a notebook in her purse with questions written down before every doctor's appointment. Margaret had been told by 2 cardiologists that she needed bypass surgery for triple vessel coronary artery disease. Both consultations were thorough by most clinical standards. Both ended with the same recommendation. The consent form was ready at the second appointment. Margaret brought her notebook. She asked the 4 questions. What happens if I don't have this surgery right now? Is there a catheter-based option for any of these vessels? What does recovery look like specifically for someone my age, with my kidney function and my history of anxiety? And what is your personal complication rate for this procedure in patients over 70 with my profile? The second cardiologist was excellent. He paused. He pulled up her specific coronary anatomy on the screen. He spent 40 minutes going through the anatomy vessel by vessel. He explained that 2 of the 3 blockages were candidates for stenting. The third was in a location where bypass provided superior coverage. The conversation that followed was not about whether surgery was good or bad. It was about whether the full surgical procedure was necessary when a hybrid approach, stenting 2 vessels, managing the third medically with aggressive pharmaceutical therapy and cardiac rehabilitation, could achieve comparable outcomes with dramatically lower procedural risk for her specific profile. Margaret chose the hybrid path 18 months ago. Last week she sent me a message. She had completed a 5-kilometer charity walk. Her cardiac rehabilitation instructor had cleared her for unsupervised exercise. Her kidney function, which had been a concern going in, had remained stable. She ended her message with this: I didn't know I was allowed to ask those questions. I thought the recommendation was the decision. Nobody told me I could push back. That sentence is why I make these videos. Here's the most important thing I will say today, and I want you to hear it clearly. A surgical recommendation is not a verdict. It is an opening position in a conversation that you have every right to participate in fully. The surgeon in that consultation room has training, experience, and technical skill that took decades to develop. That is real. That deserves respect. But what that surgeon does not have, what no one in that room has except you, is the complete picture of what your life means to you, what quality of life you are willing to trade for length of life, and what risks you would choose differently if you had the full numbers in front of you. The surgeon holds the scalpel. You hold the choice. That is not a comfortable phrase for every medical system to hear, but it is the truth that 2 decades in operating rooms has handed me, and I am not willing to soften it. The best surgery is sometimes the one that never happens. The best outcome is sometimes the one that begins with a patient who writes down 4 questions and refuses to leave the consultation room until every one of them has been answered honestly. You are that patient. You have always been that patient. You just needed someone to tell you that the questions are allowed. Before any bypass surgery recommendation, before any major cardiac procedure, there are 4 questions every patient over 60 should bring into that consultation room. Write these down. Question 1. What happens if I don't have this surgery in the next 6 to 12 months? This question measures urgency. If the coronary disease is stable, not causing unstable angina, not an immediate emergency, the honest answer may be that you have time. Time to get a second opinion. Time to try and optimize medical therapy protocol. Time to have this conversation properly. A good cardiologist will answer this directly. An answer that sounds like pressure rather than information is itself something to take note of. Question 2. Is there a catheter-based alternative for any part of this procedure? This question opens the door to PCI, to hybrid approaches, to options that may not have been offered because the consultation pathway led directly to a surgical recommendation. You are not second-guessing expertise. You are asking for the complete menu before you order. Question 3. What does recovery realistically look like for someone my age, my kidney function, my current cognitive baseline, and my living situation? Not the average patient, not the 5-year-old in the clinical trial. You, your specific body, your specific home, your specific support system. The answer should be detailed. If it is generic, Ask again. Question 4. What is your personal complication rate for this specific procedure in patients over 70 with a profile similar to mine? Surgeons track this. Centers track this. High volume, honest, surgical programs know their numbers and will tell you. If the response to this question is deflection, vagueness, or discomfort, that is, information, take it seriously. Consider seeking an additional consultation at a different center before proceeding. These 4 questions take 10 minutes. They have the potential to completely change the recommendation you receive, the procedure you undergo, or the path you choose instead. Before you close this video, I want you to do one thing. Write down question 4, just that one. What is your personal complication rate for this procedure in patients over 70 with my profile? Put it in your phone. Put it on a piece of paper in your wallet. Because the next time someone you love is sitting in a cardiac surgeon's office, that question in their pocket may be the most important thing they bring into that room. What I want to know from you, tell me in the comments, have you, or someone you love, ever been given specific, honest numbers before a bypass recommendation, not general statistics? Your specific risk profile, yes or no? I read every comment, and I will tell you that the pattern of answers to that question, across every video I have made, is the reason I keep making them. If someone in your life is facing a bypass recommendation right now, send them this video, not to frighten them, not to push them toward any particular decision, to give them what Walter did not have, the real numbers, the complete picture, the understanding that they are allowed to ask hard questions and take the time to have them answered. That one share may be the most important thing you do today. Everything I have shared today is based on peer-reviewed research and over 20 years of direct clinical experience in cardiothoracic surgery. Every statistic I cited comes from published literature, the Annals of Thoracic Surgery, the Society of Thoracic Surgeons database, the ISCHEMIA trial, the Journal of the American College of Cardiology. The references are real, the numbers are real, and every person's situation is unique. Bypass surgery has saved millions of lives. It saves lives every single day. There are patients for whom it is unambiguously the right choice and the right time. I have performed that surgery, and I am proud of what it has given people. This video is not about avoiding surgery. It is about entering that decision with complete information, honest numbers, and the understanding that you are a participant in this conversation, not a recipient of it. Bring these questions to your next appointment. Bring a family member. Take notes. You deserve a cardiologist and a surgeon who treat the conversation before the operation with the same seriousness they bring to the procedure itself. That conversation is where good medicine begins, and you are entitled to have it.